Okay, hi everybody. So today we're going to go through a simulation of airway management in the COVID era. So we're going to talk a little bit about setup, what you should have present here before you intubate, before you manage an airway, what you should do with your personnel, and then specific tools to help you get through it while protecting yourself. So obviously we're screening every patient. We're ensuring that we're donning the proper PPE. Obviously, I'm not donning the proper PPE for those types of patients right now, but for the simulation, I will have my mask on and my gloves. So first, let's talk about setup. So the decision to intubate a patient shouldn't really come lightly. Obviously, there have to be certain factors for us to do so. So in this COVID era, a lot of concern is taken to preventing aerosolization of particles, especially when managing an airway. So there's been some recent stuff that's come out about using non-rebreather and high flow nasal cannula, and that it is not as bad as we think. So these are some tools that we can use in our armamentarium here to be able to pre-oxygenate our patients on top of using a BVM. So first, you can take out your nasal cannula. You can begin pre-oxing your patient. If you can put a surgical mask on them, they can tolerate it, then that's fine. If they're breathing enough, they're breathing spontaneously, you can put a non-rebreather on them, and then a surgical mask over that as well. So when we have our BVM set up, before we want to be ready to ventilate those patients, we got to get our viral filter out, and then we also need to have our end-tidal CO2 monitor. So the way this gets set up, that you have your mask, okay, and then you put your viral filter into the mask, all right, and this goes to the patient, and then on top of that, before you get to the BVM, you place your inline CO2 filter, okay, and then you assemble like so. All right, so other equipment we're going to have ready, our eye gel in the event we can't intubate, and also our control crike. You don't have to open it, but have it ready as your plan A, your plan B, your plan C. So video laryngoscopy is preferred when we're intubating in the COVID era. You also get the best first pass or shot at first pass possible when using this. And if this is unavailable, if King Vision is unavailable, then we're recommending that you use a bougie with direct laryngoscopy. Okay, so your face is not near the patient, you can stand back a bit, and then you're protecting yourself as well. All right, so next tool we have is this nice piece of plastic here in order to protect yourself from aerosolization while you're managing the airway. So comes in one long plastic tube here. You can rip this open. Okay, there's perforation at the top. And what you're going to do, you're going to stick your arms through here, okay? And then you have a tube, right? And you can place this over the patient as you're ventilating them or pre-oxing and managing the airway. At this point, they should be sedated when you have this over them, and they should have adequate oxygenation, or you should be ventilating the patient with a BVM. So the goal is to not suffocate the patient. So we'll put that aside. Have your tube tamer out, okay? Your two oxygen sources. We obviously have the patient on the heart monitor. We're ensuring vital signs. So for airway management in the non-apneic patient or cardiac arrest patient, RSI is preferred with a paralytic. The rationale behind that is to prevent any gag, any cough, and again, to prevent the aerosolization of particles. So do obtain orders for sedation and rocuronium. So we're going to place our nasal cannula into our patient. This is for our apneic oxygenation. So this will stay in place as we're intubating the patient, okay? This is not true pre-oxygenation. Pre-oxygenation comes with if we use a non-rebreather mask, okay? And then, or if we're ventilating the patient. So if they are spontaneously breathing and they do have an adequate drive, then you can use that non-rebreather mask. If not, and you need to assist their ventilations, then use the setup we have here, and then we can go ahead and do that. But before we do that, okay, what we're going to do, we're going to place our plastic. So what you do, put this right over the patient's head. And we can ventilate and work within the plastic. So now we're protecting ourselves from aerosolization, and and we're able to manage the patient's airway. Okay. So once you deliver your medications or you're ready to manage your airway, have your assistant hand you your video laryngoscope. It should be preloaded. Recommend using the channel blade. Okay, and while I'm doing that, my assistant is going to take off the mask from the BVM. Okay, so I have a clear view of the cords right now. There's no glare or anything from this plastic piece, so I'm in the airway. Right, and then pass your tube. And the syringe should already be connected. Okay, and what you want to do is before you remove your plastic, you want to inflate that cuff. Take a BVM, make sure your filter is attached. Okay, the cuff is inflated. You want to go ahead and ventilate. Okay, so just remember, now you've closed off that trachea and you have this closed system here. So you can remove this plastic at this point. All right, you're still in your PPE, you're protecting yourself. Make sure that we secure the tube. Okay, and that we have a good end tidal reading on the monitor. We're gonna also listen to breath sounds to ensure that our patient, the tube is in place and that our patient's not having any issues. And then we continue to manage the patient from there.